Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Thank you for tuning in to Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice, brought to you by the American Academy of Pediatric Dentistry. I'm your host, Joel Berg, and thank you to our Pedo Teeth Talk sponsor, Hugh Freedy, helping us bring you great content. We could not do this without them. Be sure to visit them at www.hughfreedy.com. Well, today I'm thrilled to have with me Dr. Dan Bills, an orthodontist in the Philadelphia area. Dr. Bills has 3 offices. He comes with some amazing credentials. He trained at college, dental school at Harvard University. He had his orthodontic training at the University of Illinois. He's a board certified. He's a diplomate of the American Board of Orthodontics. He lectures actively in the U.S. and around the world and is really an expert in educating clinicians on state-of-the-art orthodontic care. He also teaches at in Philadelphia at the University of Pennsylvania and has won the Teacher of the Year award. So, Dan, we're really happy that you're here with us today to talk to us about orthodontic care in children.
Oh, Joel, I'm thrilled to be here. Thank you so much for the honor.
Yes, and let's just jump right into some of the hot topics that I know that our audience will be really interested in your expert opinion about. And, we talk a lot about phase 1 treatment, and maybe you could just tell us, what is phase 1 treatment? I mean, that's kind of a rhetorical question, but I want us to hear your definition, and how do you determine when it's indicated?
Yeah, it's a great question. And like a lot of things in orthodontics, it's one of those things that everybody seems to have their own opinion on. And I don't think there's necessarily one right answer. But for me, phase 1 treatment is something that we're doing at a younger age to intercept problems that, in my opinion, can't be addressed later in life, or possibly would be more difficult to address later in life, or if they're not addressed, could cause some irreversible damage later on. So in my office, when I'm thinking about who needs phase 1, it really is a very clear subset of problems. So it would be somebody with a significant maxillary transverse problem that requires skeletal expansion. It would be a patient with severe overjet to the point where they're going to trip and fall on the playground and, end up damaging their upper incisors. It would be the case where there were some significant psychosocial concerns where, the parents were talking about the child getting picked on at school because of the alignment of their front teeth. And then the big thing for me and a big passion of mine, especially being married to a pediatric dentist, is being able to intercede when I see ectopically positioned maxillary canines and, making sure that we're actively expanding when we need to expand, removing primary teeth when we need to remove them in order to help guide the erupting maxillary canines. And we've been very successful at I can't say completely eliminating, but very much reducing the impacted canines that we see in our practice when we catch kids early.
So would you say, Dan, that if somebody's going to choose to do phase 1 treatment, it's not necessarily fair to say it's going to reduce the amount of time required for phase 2 treatment, it's just that it's necessary for other reasons? Is that accurate?
That is pretty accurate in my opinion. And what you'll hear a lot from me today, I'll try to decipher fact from opinion. The facts are pretty clear that, the studies that have been done recently, especially by Dr. Prophet, who recently passed away, were pretty clear that, you're not necessarily reducing the time in phase 2, but what we're trying to do is handle things that need to be addressed early in order to prevent bigger problems down the road, like, the impacted canine example.
That's great. That's helpful. So I want to ask you, this is something that I deal with, and when I practice, if I'm having a initial exam or a recare day, a whole bunch of kids in that day, as we all like to do, I sometimes feel like every patient needs an ortho consult or referral, and I love that I'm going to have an orthodontist with me. But what would you say in terms of the best age, in general? I know you can't make a general statement specifically, but if you could just sort of generalize now, the best age for the first orthodontic referral, and why is that the right age?
Yeah. So, and first of all, I love you for thinking every patient needs an ortho consult. That's great. But the correct age in the American Association of Orthodontists, really pushes the consult by the age of 7 or earlier if the dentist sees that there's, a bigger problem going on. For me, I think 7's perfect. And less than probably 5% of 7-year-olds that I see need any sort of treatment. But for the handful that do, if we miss them at that age, it can be much harder to treat down the road and sometimes even impossible.
Okay. I want to shift to something else that comes up quite often, and that is having to do with the primary canine extraction. You talked about permanent canine impaction before. Let's shift to primary canines. You get all kinds of different opinions. We see residents coming in and to faculty from different training programs getting different information. What is your take on when and if to extract primary canines?
No, that's an amazing question, and it actually is a huge passion of mine. So most of the work on that, I'm sure you're familiar with, Tony Gianelli out of Boston and the Bacchetti work that looked at that specifically, and with palatally impacted canines, especially being able to expand and then remove primary canines at an earlier age, I think is pretty clear in the literature that it's going to decrease the risk of future impaction, especially if the canines are positioned palatally. So if I see, in my office, if I'm worried at all, once a canine crosses over a lateral incisor even a little bit, I'm leaning towards primary canine extractions. If there's a corresponding maxillary transverse problem, I would expand first, utilize a space maintainer, and then remove primary canines. And on occasion, primary first molars if I think it's necessary.
Okay. We mentioned space maintenance. I want to ask a question about space maintenance, something that comes up for us in pediatric dentistry every single day. And that is when the first permanent molars are fully erupted in occlusion, is there a need for space maintenance if the primary second molars are in place? And what about, if they're not? And I know there may be different circumstances. What's your thought on that?
Yeah, and this is where it's an amazing question. So for me, I walk in two different worlds, right? I walk in an academic world where I'm very big on evidence-based dentistry, and I've read the same studies that you have. And as I mentioned, my wife's a pediatric dentist, and, I've read all of her articles, and I understand in the literature, first molars fully erupted in occlusion. If a primary first molar is extracted, that there is literature to support the fact that space maintenance is not needed. I show my residents case after case after case, which obviously are just case reports, so I don't have the evidence behind it other than clinical experience, to tell you that I still recommend using space maintainers in those cases. I've seen plenty of examples where we end up losing.
So would you say uniformly that you should have a space maintainer when the second primary molars are in place?
So I try to avoid using words like uniformly because I do understand that it's a controversial topic. I can tell you uniformly for me in my practice, yes, I do use it. I'd rather take the chance and have an extra appliance in there than end up losing space and having blocked out premolars down the road.
So what about doing a space analysis of some sort to determine if there's already loss or there's adequate space, some kind of analytic test? Would that be appropriate or not?
It definitely would be. And especially with all the digital software that we have out today, that's a lot easier than it used to be.
You could just push a button and have it do it for you.
Yeah, well, to some extent, yeah.
To some extent. So there's a lot of, we have limited time, but there are a lot of controversial topics in orthodontics these days. And, we could probably enumerate many, but I just wanted to get, for the pediatric dental community, what would you want us to know about? What are those topics and what do we need to know?
Yeah, great question again. And I feel like these are the same debates or controversies or, topics that have been discussed and debated for years. And I guess the big ones would be extraction versus non-extraction orthodontic treatment, expansion versus non-expansion. There are orthodontists and companies that talk about the fact that expansion's not needed with their fixed appliances. And then that obviously leads to superiority or claims of superiority with specific bracket systems that are out there. Personally, there, without a doubt, is a time and a place for extractions. And there's been study after study after study that there is nothing wrong with orthodontic extractions in the right case. And we do still extract when we need to, not as much as we used to, but we still definitely need to do it. Profile reasons, significant proclination of upper incisors where we want to get those incisors nice and upright. The expansion, non-expansion, quite frankly, I don't really understand that one. I think that data are pretty clear that there's a maxillary skeletal transverse deficiency, that skeletal expansion is indicated, although there are people that choose not to do that, and certainly that's their prerogative. The big passion I have is a lot of the discussion, a lot of it driven by orthodontic companies about superiority of certain bracket systems, and specifically certain self-ligating bracket systems. I am a self-ligating user and have been for 11 years, but never in a million years would I, sell my practice as being superior to somebody else's. The data are incredibly clear that there's nothing better about self-ligating brackets other than personal preference of the user. So I would tell all of your listeners, and I know they probably all know this, if there's a doctor that they're working with or referring to that's claiming that their braces are better than somebody else's, I would ask them to, show me the literature on that, because a good analogy is you could give a good orthodontist the cheapest bracket on the planet and they'll find a way to straighten teeth and make it work.
It's about the technique and the experience and the diagnosis and treatment planning.
100% about diagnosis and treatment planning.
Yeah. Regarding that, would you say that's been reflected in the sales of those brackets? Are you seeing that that your colleagues are just not using them as much for that reason? The self-ligating, that is?
I actually don't think that at all. And like I said, I am a self-ligating user, and I firmly believe that there are advantages to me as the clinician. And there are things like decreased chair time, my ability to stretch out treatment intervals. All of that is well documented. There are hygiene benefits of not having elastomerics, O-rings around each of the brackets. That's all been documented. But the clinical superiority piece, I think, still rests in the hands of the doctor that's diagnosing and treating.
Provider, which is true with clinical dentistry in general. Restorative, it's not about the material, it's about the technique. It's almost always the case.
Oh, without a doubt.
I've seen that over and over. You mentioned hygiene. That brings up a whole host of questions, but we'll just jump into that for a moment. And that is that, I see we all in pediatric dentistry see a lot of patients who are undergoing orthodontic treatment. And you wonder if they even knew that they had to brush their teeth sometimes. And you're just sort of asking for a bigger problem. They're going to have beautifully straightened, perfectly in occlusion teeth that when the brackets come off, they're going to have all these white demineralized lesions. So, what's your protocol for managing that before treatment and during treatment? And what should we be doing together on this?
Yeah, there's a lot in that question. And
it's a loaded question.
No, it's a great question. And it's one of those things that if you were to ask me my least favorite part of my job, that's it. And that's, working with kids that are not necessarily motivated to follow our instructions, and knowing that if they don't, the outcome can be catastrophic. So for us, it starts with education from day one. And we use some pretty high-tech patient education software, both in the consult rooms and chair side, to go through everything that will go wrong if they don't follow the instructions, and also going over proper technique. We have the ability to send text message videos of some of these hygiene, instructional videos to patients, so they have them at home, and it really reinforces what we're talking about while they're in our office. We then give them a hygiene score every time they come in, and we review, videos and education tips when we need to. Any score below a C, letter goes to the patient, letter goes to the general dentist or the pediatric dentist, and then 2 C's or below in a row, and we're removing wires, and we're at that point, if it doesn't improve, we remove brackets early, and it's not something we love to do, but we will do it when we need to. We're also
sounds like a pretty aggressive intervention, but I bet that works, doesn't it?
You would think it would work. You think it would work better than it does, and for some patients it does. But there are still others, especially with what I'm sure you guys wrestle with every day, and the diet that is going on in today's youth with sodas and sports drinks and everything else. A lot of times it might not even be brushing and flossing. It could be, what's in their diet. So, we struggle with it. What I would want your listeners to know is how important it is to us that there's a team approach to this. So with all of our dental offices that we work with, we're in constant communication about this, and we do our best to get them in to see their pediatric dentist or their general dentist every 3 months if we need to, in order to keep the hygiene under control during ortho.
I always say that nothing can beat a bad diet in terms of destroying your teeth. So
without a doubt,
it is important not to only focus on brushing, but on diet.
Exactly. And then there's great products out there as well. We're using new disclosing toothpaste we give to all of our patients that are incredibly effective. We've got obviously high fluoride toothpaste when we need to, if we're worried about decal. And then, there are options for products that, high fluoride products that we can have them use in their retainers when they're done, if there's some mild white spots that we want to work on.
Excellent. Let's take a moment here for a word from our sponsor.
Hugh Freedy is the global leader in dental instrument manufacturing and infection prevention solutions that keep you performing at your best. For more information on Hugh Freedy products, visit hughfreedy.com/AAPD-crowns. That's hugh-freedy.com/AAPD-crowns. And enter the promo code 2682 if placing an order for pedo crowns.
We are here with Dr. Dan Bills, and we're talking about the topic of orthodontics and as it relates to us as pediatric dentists. And we were just talking about the oral hygiene issues, and that brings up the general topic of the relationship between the pediatric dentist and the orthodontist. It's an important subject. We see the kids. We refer them in those instances to orthodontists. And do you see this relationship as a positive experience? And what are some of your best recommendations to make this relationship, which is usually very good, even better?
Yeah. And, I did mention earlier, but just to, make it clear, for me, this is not just opinion. This is my life. My wife is an incredibly talented pediatric dentist. So
you better be nice.
Exactly. So the relationship has obviously been a part of my entire practice career. And I've watched different versions of that relationship and different iterations. And it now has really become a big passion of mine. And I'm really honored. In the next 9 months, I'll be presenting this at your annual meeting. I'll be presenting it at our AAO annual session, and often also at the Dolphin users meeting, our software meeting. And it's becoming something that everybody's talking about. And people are talking about it both in the ortho community and certainly in the pedo community. And to answer your question, if done correctly, I think this is an incredibly powerful, positive relationship. You guys, have the kids in your practice, the proper times to refer. There's nobody more educated about orthodontics other than orthodontists than pediatric dentists. And I've loved, and not just my wife, I have tremendous working relationships with other pediatric dentists. It's so nice to talk to people that really understand these problems and get the patients in to see us at the right times. There are also different business strategies. There's
structures of the relationships.
Yes, exactly. It's a growing trend that I see with pediatric dentists bringing in-house ortho. I've seen orthodontists bringing in-house pediatric dentists. I've seen business partnerships where two specialists or more than two go into practice together. I've also seen, and this seems to be one of the easier things to do, and it's really is what my wife and I do. We're two separate practices, but we do a rent share. So we're two separate practices, two separate staffs, separate brands, separate identities, but we practice under the same roof, and we are able to cut our overhead with things like, a pan-ceph and sterilization equipment and, printers and computers and all of that stuff. And that's really been very beneficial, and so
would you say that's the best structure? I mean, there are various structures that you can imagine. Is that your recommendation, is to do what you and your wife do, separate practices, the same roof?
I knew you were going to ask that question. So kind of what I mentioned before, I try to avoid using things like words like best, because every situation's different. I think it's probably the easiest. And I think it's the one that probably has the least amount of entanglements, because your practices are still separate. You're literally just sharing a space. I've heard a lot of not so great stories one way or the other with continuity of care in some of the other scenarios. So let's say the pediatric dentist brings in a young associate orthodontist who then leaves in a year or two, and then they have to bring in another one and then bring in another one. So I would say, and in my opinion, the two best, or what I've seen the most success with, is probably a way I'm more comfortable with saying it, would be the rent share. And then if you really do find somebody that you could be a true business partner with, where you're both invested in the practice, and the continuity of care issue isn't a concern. And I think that could be very, very successful as well.
I think clarity of the relationship, regardless of the structure, just as everything is clear and the expectations are clearly understood by all parties,
Exactly.
including the patient. Obviously,
Exactly.
They often are confused about, so I think that's all very important. Let's kind of shift to consumer marketing. There's a lot of marketing. We'll come into some technology topics as we close in a few minutes, but let's talk about direct-to-consumer marketing. We're seeing a ton of this.
Yes.
Everywhere, related to orthodontics as much, perhaps more than any other area in the profession. And what do you think about this strategy, and how does it work, and what are the pluses and minuses of that?
Well, there's two different pieces. So is your question revolving around direct-to-consumer marketing from the orthodontist to the consumer, or
Both.
Directly from the company to the consumer?
Both. Let's take both of them. Let's quickly talk about the first one, from the orthodontist to the consumer. I've seen some of that, not as much as the latter.
Yeah, for us, and this is something that we've been in tune with for years, and I think a lot of my pediatric dentist colleagues are now realizing how strong this can be, especially as there are a lot of general dentists that are keeping more pedo in-house and they're keeping more ortho in-house. There is no better way, in my opinion, to build your practice than to make connections with your existing patients first, but then going direct to consumer to allow people to find out about how great your ortho practice is or how great your pedo practice is. So, we've really focused in the last 7, 8, 9 years on our web presence first and foremost. So, having an incredibly good, incredibly engaging, very video heavy, very emotional website with obviously good SEO built into it. And that's been fantastic for us. The other would be your presence on review sites like Google, and making sure that your online reputation is where it needs to be. And then, you can't downplay how important social media is in our culture today, and being able to speak the language of people out there and who your consumer is. And those really are a lot of the people on Facebook and Twitter and Instagram.
Other sites. Let's jump to the other one quickly, the consumer being targeted from the industry related to
I was hoping we were
orthodontics.
going to run out of time before that one.
No, we got a couple minutes left.
No, and it's one of those things. So this obviously is a very hot button issue in orthodontics right now, and I'm sure all your listeners are aware, because you can't turn on a television.
Do it yourself. I'm talking about also. Let's just hone in on the do it yourself idea.
Do it yourself. Yep, you can't turn on a television or watch a sporting event without seeing a commercial.
Right.
It really is. It's a challenge, and anyone who's in a specialty like ortho or pedo or general dentist even understands that supervision, diagnosis, treatment planning is an essential part of what we do. So as an orthodontist, I don't worry that somehow we're going to get factored out of the equation, because, I know even something like with a clear aligner case, we're very good at clear aligner therapy in our office. But if you took away attachments and you took away interproximal reduction and you took away my ability to see the patient on regular intervals and intercede when we need to, that treatment is not going to work, even if I spent the hours on the setup that I do on my clear aligner cases. So, the model doesn't scare me as a business owner. The model makes me a little nervous for patient protection, to be honest with you. And, I do worry that it's going to disparage our profession as a whole if patients aren't happy with the care that they're receiving. That's probably my biggest concern.
Well, I think it's clear, and our audience understands that, and I'm happy to hear your take on that, which is my take. And I mean, the same thing. If you go to YouTube, you can find 100 videos on how to do a restoration on yourself using your Dremel tools in the garage. I mean, it's insane. So, this is not unique to orthodontics. It's just more prevalent at the moment. And I suspect that it'll kind of settle itself as results evolve. We'll see what happens going forward.
Without a doubt.
Maybe we have time for one more quick technology. That's sort of in the technology, or if you call it that, tech category.
Yeah.
But what are are there one or two other technology things that are of interest to us?
Yeah, and something, again, I see this every day with the young pedo patients that we have. But the biggest thing for us, we adopted intraoral scanners very early. Probably they entered our practice probably 6-7 years ago, and they became mainstream for us about 5 years ago. So we haven't taken alginate impressions in our office in probably 4 years. And that's been great, especially for our young pedo patients where, little mouths, a lot of alginate, and, is a recipe for an uncomfortable patient experience. So for example, if I've got an 8-year-old that needs an RPE, a rapid palatal expander, we're scanning, we're placing separators that same day. Patient comes back 2 weeks later and we can deliver the appliance. So no more impressions, no more band fitting.
Fantastic, yeah.
And that's been really great for us, and our pedo patients love it.
I have a colleague at the University of Washington who is a pediatric dentist who has completed a scanning for all of his cases, regardless of the need for impression making.
Exactly.
I think that we'll see that across the board in years ahead. Anything else? Any other last technologies?
That's really the big one, and I did want to point out I'll be going into a lot of detail with that at my lecture at the AAPD too. So it's the workflow with that.
That's a perfect plug.
Yeah, the workflow with that is very important, and it's not something that you can just scan and send to your local lab and have them make the appliance fit the way you need it to fit. So it's very workflow specific, and I would encourage any of your listeners, shoot me an email. If you have questions, I'd love to help people work through that and save you some of the headaches that I had early on.
Well, that's perfect, Dan, to close with. And I want to remind our audience that Dr. Bills will be speaking at the annual session of the American Academy of Pediatric Dentistry in May 19 in Chicago. It's going to be a great course. You've heard sort of a sneak preview of some of the very interesting subjects, and you're going to touch on most of these, if not all of them, in addition to other things. So that's fantastic. And I thank you, Dr. Bills, for giving us a lot of great information in a short period of time. You teased us for wanting more, but that's great for the moment. And I thank our audience for tuning into Pedo Teeth Talk. We try to bring you the contemporary issues important to you in your practice, and we bring this to you from the American Academy of Pediatric Dentistry. I'm your host, Joel Berg, and I thank you very much.
Thank you, Joel.
We'll see you next time.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.